where are you currently? Where are you located? And if you may share us to us, where do you currently work?
I am Riza. Currently, I'm here in the Kingdom of Saudi Arabia, specifically in Riyadh, and currently I'm working as a clinical educator at King Fahad Medical City, here, same here in Riyadh.
Thank you so much. Uh, Next question is, Ma'am Riza, where are you originally from?
Okay. My actually, I was born in Manila, but
Mm-hmm.
then we then decided to transfer to Leyte.
Nice.
But currently, I'm living in Bohol.
Bohol. All right. Thank you, ma'am. And do you speak other dialect besides Tagalog?
Uh, Definitely Visaya.
Bisaya. Oh, nice, nice. That's good.
Visaya.
And that's the dialect in Leyte, correct?
Yes, Cebuano.
Cebuano. Awesome. Thank you, thank you. Now the next question, ma'am, is where did you get your respiratory care or respiratory therapy training or degree?
Okay. I took it at University Perpetual Health Laguna.
Mm-hmm.
Graduated by the year I think 1995.
1995. Uh,
Yes,
if
quite
I may do the math, how long have you been in the respiratory therapy industry, ma'am?
decades.
Decades. Decades. So that's more than 2 decades. That's good to know. And from we have very good therapists that have joined us and are supporting us from University of Perpetual Health from different campuses. So thank you. Shout out to all our perps, colleagues, and students who are watching us today. And why did you select, ma'am, to become a respiratory therapist?
Actually, to be honest with you, when I finished my first degree, which was BS Biology, my plan was really to proceed with medicine, but for some reason I wasn't
Mm-hmm.
able to do that. And then by that time, respiratory therapist is not yet that famous.
Mm-hmm.
So at first I was thinking to take physical therapy. But then, because they are in demand at that time, so they wanted me to take all the courses, including including all the subjects that I have finished. So then I was said, okay, I will not do that. And until one of the staff there was asking me, why don't you take respiratory therapy?
Mm-hmm.
So I was thinking by then, okay, so nursing is booming by now, occupational therapies as well, and physical therapies as
Mm-hmm.
well. So I was thinking maybe by the time I finish this course, that the demand for respiratory therapies will go up.
Mm-hmm.
So I was really lucky to choose respiratory therapy because the moment I graduated, I got a good job, and
Mm-hmm.
then and, and until now, this is my bread and butter. So
Oh,
no regrets at all.
that's good. Very good decision, ma'am. And I know we have a lot of, respiratory therapy degree could be a ladder to get into a doctor of medicine program. And, it is a very good profession, especially nowadays. I know before it wasn't that famous yet. Nobody know what an RT does. I mean, even up to now, we still struggle with us expressing ourselves and letting everybody know what a respiratory therapist does. But with the COVID-19, a lot of people do know now who respiratory therapists are. Thank you for sharing that. And ma'am, if I may ask, what do you think makes the respiratory therapy profession unique?
Unique.
Uh huh.
First and foremost, we are always we're a frontliner. Okay,
Mm-hmm.
so we save life.
Mm-hmm.
So I think without us, and by the way, this is what I can tell all of you who are listening there. Here in King Fahad, there's a high demand as well as high respect when it comes to respiratory therapies.
Mm-hmm.
So whenever they see something wrong with the patients at the ICU, if they can call on the doctor, the first whom they will call is definitely the RT,
Mm-hmm.
because we all well rounded, we know everything.
Mm-hmm.
So we don't. deal with the lung itself. We are well versed when it comes to dealing critical patients. So
Mhm.
I should say that, okay, following the doctors, I think it is us who they always call.
Mm-hmm. That's very good, ma'am. And um, that's very good to know that in the country where you currently work at, or the city where you currently work at, that the respiratory therapists are well respected. And I've heard from some colleagues that respiratory therapists are well respected in the Kingdom Saudi Arabia and surrounding Middle Eastern countries, which should be universal. And I'll be honest with to all our viewers, even in the United States, it depends on where you currently work.
Mhm.
Fortunately for me, I have worked with hospitals that do respect respiratory therapists. Before they call a rapid response team or they would call the doctor, they'll ask for a respiratory therapist, as you mentioned, because we just don't deal with the lungs. We deal with the whole. We do a holistic approach. We deal with the lungs, but we also could do so much more with the heart. We could also we also know, we should also know our laboratories, our imaging studies, and what interventions, because respiratory therapists, as you said, we're well rounded. We work at medical surgical floor to the ICU, from neonates to adults. So we have that bigger picture that we see compared to our nurses who works on that specific unit. So it's really good to know. And ma'am, next question would be, um, besides working at your current institution, where else have you worked? If you may share
Okay,
that to us.
so history, huh?
Yes.
History. Okay, so I started working at the University of Santo Tomas Hospital.
Oh, nice.
I stayed there for, I think, almost 8 years.
Mm-hmm.
Okay, then and at the same time, I teach
Mm-hmm.
at the University of Perpetual Help. So I
Mm-hmm.
did part-time job.
Mm-hmm.
Then after that, I moved to Singapore, where I work at Tan Tock Seng Hospital for another 8 years.
Mm-hmm.
Then here am I now at the Kingdom of Saudi Arabia. So plenty of experience, both academic and clinical.
That's very good, ma'am. Um, working at in the Philippines, in Manila, particularly at the University of Santo Tomas, and very good hospital, university or teaching hospital. We know that, and also you have worked at Tak Tak Seng in Singapore, and now you are in the Middle East. Now my follow up question with that, and you both work at the academe and the clinical side, which I, would really, I do really think that, being an educator is very good. It's a very good, respiratory position to be in. But also, I personally, I do believe that, educators who currently works at bedside too have the most, they have the reality at the current moment. They could relate
True.
what the theories are in the book, and and they could say, hey, but right now this is what we're doing, because we know medicine is evolving. Do you think, ma'am? And
What?
follow-up question with that, so sorry. um, Follow-up question with that is that, so how different it is, we're not gonna we're how different it is from the Philippines to Singapore and going now to Saudi Arabia. If you can just,
Oh,
yeah, share that to us, because a lot of viewers
that's
wanted
a
to
hard
know.
question. That is a little bit hard question because
Mm-hmm.
comparing one hospital to another hospital is a little bit okay. I don't know how to say
Mm-hmm.
it, but then I have a big respect with I have a big respect with University of Santo Tomas because without
Mm-hmm.
them I would be here.
Mm-hmm.
Okay, so I had my training in University of Santo Tomas, and then uh, the practice is quite different, to be
Mm-hmm.
honest with you. So when it comes to liberty working as an RT,
Mm-hmm.
okay, I think it's more of working abroad.
Mm-hmm.
Okay, in Singapore, okay, how will I tell it to you? In Singapore, there's a lot of things that I have learned.
Mm-hmm.
Okay, first that was the first hospital where I worked outside of the Philippines, and
Mm-hmm.
then the liberty to work, to think, and then to communicate with the
Mm-hmm.
doctors, and then they respect us so much. They're
Mm-hmm.
asking a lot of your experiences, and then
Mm-hmm.
I gained a lot from Singapore. I remembered one doctor there who was so strict, and really I learned a lot from that doctor.
Mm-hmm.
So it just whenever he says something, you have to listen, and then when he orders something, so I always listen to them.
Mm-hmm.
And in Singapore, we are under the neuro. So I
Mm-hmm.
learned a lot from those neuro doctors there.
Mm-hmm.
So I got all my experience from the Philippines and then from Singapore, and then now that I am here in
Mm-hmm.
Saudi, it's different because here in Saudi, I should say again a lot of liberty, because
Mm-hmm.
here, like what I've told you, they're always asking
Mm-hmm.
second in line.
Mm-hmm.
Second in line are always the artists.
Mm-hmm.
So whenever the doctor is not around, so the
Mm-hmm.
nurses will call the artist.
Mm-hmm.
So we are well rounded, and then more liberty, more of the expression, more on clinical, and then now that I'm in education, so I think it's a big privilege
Mm-hmm.
having the theory and applying it to the clinical. So I think it's wonderful. So all of those hospitals where I work with, I
Mm-hmm.
should say that I should be very grateful to them.
Thank you, ma'am. Thank you. And that's what we're trying to get to is just to see the picture and you know I've had some personal accounts. We're not going to be critical, but it's different. But we can say that the respiratory therapy profession, both here in the U.S. or wherever we are in the Philippines, it's still an early profession that it's still growing and it needs a lot of support. A lot of support for everyone, but also I think it's very important to know that as respiratory therapists, us respiratory therapists needs to be united to support and advocate for our profession. Even here in the U.S., I advocate for the respiratory profession. With the little things that I do, and as I am telling my colleagues here that you're a respiratory therapist. Whenever we do some advocacy or be involved in your professional organization, do something different. Because if we just keep talking and talking, nothing is gonna happen. We need some action. But anyway, it's good to know. There's a lot of improvements everywhere, but I'm glad that and proud to say that a fellow Filipino is representing the respiratory therapy profession in Saudi Arabia so well. So thank you for that, ma'am. And I believe that our Filipino respiratory therapists, wherever they may be, if they're given a chance, if they are trained, and if they're given the resources to perform, to do good, and Filipino artists will do really good because we are very hardworking people, and we got
So
so much respect to to number one ourselves and our colleagues too. So thank you, and ma'am. So question is, you already mentioned, you kind of answered this question is, what do you kind of like your specialty right now? And you said you're a educator and you're currently in education at the clinical side, right? I mean, on the hospital side. Is that correct?
yeah, yes.
And before, ma'am, if if you are a say a practicing bedside respiratory therapist, where do you consider yourself to be very strong at? Would it be the neonatal pediatric side or the adult side or the clinic side?
Okay. Okay. So even back in Singapore, I always work at the
Mm-hmm.
adult case. So mainly working in surgical ICU, medical ICU, neuro
Mm-hmm.
ICU, and then when I transferred here in Kingdom of Saudi Arabia, I first worked at bedside
Yeah.
for 3 long years.
Mm-hmm.
Yeah, 3 long years, and then over here I mean King Fahad, we don't have something like a core RT. So I mean
Mm-hmm.
to say, we don't just advocating just okay, I will just be assigned in adult ICU. There's no such thing as that.
Mm-hmm.
So we are well rounded. So we are rotating in all ICUs.
Mm-hmm.
Actually, over here we are rotating at 7 different units,
Mm-hmm.
such as med ICU, neuro ICU,
Mm-hmm.
CV ICU, coronary ICU.
Mm-hmm.
What else? So we have. a pediatric
Mm-hmm.
ICU, pediatric CBICU,
Mm-hmm.
as well as a neonatal ICU.
Mm-hmm.
But I should say, if you will ask me to which unit would I prefer to work on,
Mm-hmm.
I'm honest enough, I love adults.
Mm-hmm.
I love to deal with
Yeah.
mainly because I have some problem with my eyes. So going in ICU,
Mm-hmm.
looking at those small tube,
Mm-hmm.
retracting for almost just point something of the
Yeah.
ETT,
Mm-hmm.
it's hard for me.
Right.
So yeah, I love working
Mm-hmm.
with adult.
Yeah.
So I don't care neuro, whether it's medical, whether it's
Mm-hmm.
cardio, as well as just adult. It's fine with me.
Mm-hmm. That's very good, ma'am. And you know, I've worked at some hospitals that you really have to be a well-rounded RT. So you know, today you might be on NICU, neonatal ICU. Tomorrow you'll be an adult ICU, or tomorrow
Yes.
you'll be at medical surgical floors. You just don't know, and that's good because respiratory therapist has mentioned. You know, we work from the first breath until to the last breath, so we have to work those areas, and uh, if I may ask, ma'am, your institution, King Fahad or Medical Center, it's kind of like it's like a highest level of care, right? Because you mentioned you have different specialties. You deal with trauma,
Yes.
different
Yes.
specialties. Is that correct? How big is the hospital? If you can just approximate how many beds capacities and.
Thousand, thousand,
Mm-hmm.
thousand bed capacity. It's
Mm-hmm.
very big. It's very
Mm-hmm.
big, to be honest with you. A lot of specialization.
Mm-hmm.
So yes, it is.
And it's in
And
the.
even we have a
Mm-hmm.
research center, then
Oh.
teaching,
Oh,
training.
that's good.
So
Mm-hmm.
you can now have an idea how
Right.
big is the institution.
Yeah, and it's in the capital of Saudi Arabia, right? Riyadh.
Yes, Riyadh.
Okay, that's awesome, and thank you. And how many RTs are there in your institution? I'm just curious because it's such a big
Oh,
hospital.
yeah. Would you believe that we are, I think, almost now nearing 300?
Wow, and how many staff RTs per shift? Like
A
average
lot.
20s,
Yeah,
30s.
actually, we are divided into different sections.
Oh,
Okay, so we
okay.
have the education, and then we have the outpatient department
Mm-hmm.
for which the TFT people belong, the sleep people
Mm-hmm.
belong, and then we have critical ICU, and then
Mm-hmm.
we have the general ICU.
Mm-hmm.
So I would just mention about the critical care. So I
Mm-hmm.
think for the critical care, in just one shift, I mean only in the morning because we have a 12-hour shift, so
Mm-hmm.
7 a.m. to 7 p.m. In just one shift, I think we have around 20 plus artists working.
Wow.
Okay, 20 plus working,
Just in
and
the
then another
ICU.
20 plus, yeah, in just 12 shifts. And
Wow.
just imagine that will endorse to another
Uh huh.
20 something artists
Yeah.
night. So you can now have an idea how big the
Yeah.
institution is.
That's awesome. It's such a big hospital, and it's a lot of RTs in there. It's very good, and thank you for sharing that. And our viewers here, which we have plenty today. We thank you, everyone who's watching us. Shout out to all of you. Um, Before we move on, I would like to remind our audience that you can ask us any questions that you may have at any point, and I will read those comments um, to Miss Riza, and we will try to answer all these questions that you may have. But if you just want to do a shout out, please do so. I would like to know who's watching us today. So, all right, shout out here. We got Kyla, Francesca here, Christopher Lim watching from Edmonton, Canada. Thank you, sir. And then we got Katrina Digamo watching from Cebu, Philippines. Ma'am, we've got somebody watching us from Cebu, and then
Oh,
yes,
oh,
awesome. And then we got
hello.
here again. Go ahead, ma'am.
Hi, hi, mga kababayan ako diha sa Cebu. Kumusta na mo diha?
It's awesome. And
So I'm speaking in my dialect, huh?
yeah, that's really good. Thank you for that. And then also, Mr. Christopher Lim said that I agree. Saudi RT policies are more liberty compared to other countries. And Mr. Christopher Lim, have you also worked in Saudi before? I know we have some colleagues that have moved to the U.S. and Canada that are also now are moving to other countries too. So That's good. And yeah, thank you. And also, please do let us know who you are, where you watching from, what institution, or where are you from. We love to hear from you. If you have any questions at any point, please, shoot us a comment on the comment section, and we will read that to you. Now, moving on, Miss Riza. Now, with all this discussion, and we get to know you more, and we really appreciate you sharing all this, information to us, and we do truly appreciate it. Now, ma'am, if I may ask you, what are your message to aspiring respiratory therapists or respiratory care practitioners that are currently watching us today?
Okay. Love your profession,
Mm-hmm.
the passion itself, the dedication.
Mm-hmm.
So I always, I'm always telling this even to my students. Okay, so uh, you have to have the heart when you are doing your profession. It's not like, okay, I'm going to get this degree just to what, just to earn a living.
Mm-hmm.
So love your profession, and then don't stop. Still strive more, and then go for some research, okay, ask a lot of people, okay, gain more experience, and then once you have this all, okay, stay grounded, always stay grounded. And with all of this, having said so, then you try to what, share your whatever you have, whatever knowledge you have to others, because at
Mm-hmm.
the end, we we should keep on growing. Okay, we should help each other. So
Mm-hmm.
I think that's my message to everyone. Okay,
Mm-hmm.
keep grounded, continue the profession, love what you are doing right now, and then keep the passion with you.
Mm-hmm. Thank you so much for that, ma'am. And now, with the COVID-19 pandemic that is affecting all of us worldwide, and as frontliners, you mentioned, we really have worked hard in the past year, and we continue to do so. And now, what's your message to our fellow respiratory therapists that are kind of, their morale are low right now, they're tired, some people want to give up, want to take a break, some people that, they feel like they're not being recognized as much, they're not being supported, to uplift their spirit, ma'am. What's your message to our fellow respiratory therapists out there?
Keep the faith.
Mm-hmm.
Keep the faith.
Mm-hmm.
Love work. To be honest with you, I will consider myself one of those. Why? Because it's
Mm-hmm.
now, I've been away from the family for 2 years now.
Yeah.
And even until now, granted any vacation. So just
Mm-hmm.
imagine, we are already exhausted. But then because of uh, what we promised, that we want to serve mankind. Okay, this is our profession. We swear, we have an oath that we will serve them. So always keep the faith, and always think like, okay, I'm doing this one. It's not just for me, but then I'm helping the whole world. And most probably, by the way, uh, this pandemic will soon go to an end, and
Mm-hmm.
every one of us, if we won the battle, and that we will say that, okay, at last we were able to do this.
Mm-hmm.
And by the way, I experienced this one before when I was
Mm-hmm.
yet in Singapore. I was there during the SARS time, and I
Mm-hmm.
thought that when the SARS broke up,
Mm-hmm.
I was very, very new. I think I was just, I think, on my third month when the SARS came. And then I was so scared. And then, but with the unity of our profession, we were able to overpass. And then,
Mm-hmm.
the joy that you were able to help mankind. So
Mm-hmm.
keep the faith.
Yeah.
This one will end soon.
Yeah.
So I think that's it.
Thank you so much. Very wonderful message. And again, we are all here with you. Our thoughts and prayers are all with you, our colleagues. Please do take care of yourself. Take care of your families. Again, just keep the faith, as Mom Risa said. It's very helpful. It's very powerful that you keep your faith and continue to love your profession. Again, we're doing so much, for a lot of people and for their families. Even if the outcome isn't great, but that you've give your 100% every single time to help our patients that are in need. And also, as you, ma'am, like you are overseas Filipino worker. You've been away with family for 2 years. We thank you, ma'am, for everything that you do, and thank you for your sacrifice. And during this time, though it's easier to communicate via Facebook or whatever it is, Messenger, whatever it is, the technology is there to connect virtually. But then again, some people could go home after their 12-hour, 13-hour long shift, to be with their family. So be thankful for what you have now and continue to just keep your faith. And we are here with you. If any of you need anything, need somebody to talk to, I know mental health right now is taking a heavy toll for a lot of us. Please do reach out to any of us, and we're here to listen and we're here to support you. Again, it's a small respiratory therapy world. We should, as Mom Risa said, we're here to support. We need to support each other, and we are all in this battle together. Okay, thank you so much, and shout out his or her Facebook page. Is name is RT Pines. Currently, he or she said Hamad Medical Corporation, Women's Wellness Research Center, NICU RT. Shout out to you. If you can share us your name, please be safe wherever you are, and we thank you for watching us on this episode. And from Dr. Noel Tiburcio, sorry I was late, just arrived watching from
Oh,
Antipolo City. Thanks, Michael and Riza. More power to all respiratory care practitioners. Thanks for all what you do. Please keep safe always, and God bless. Thank you for your support and watching us today, Dr. Noel Tiburcio. And we do appreciate your support every single time. And thank you for your service to this wonderful profession. Shout out to all our respiratory care practitioners worldwide. Now, as a lot of our audience are waiting for, we will now proceed shortly with the Miss Riza's presentation. APRV, from initiation to clinical application. So please stand by. We will be right back, folks. Just stand by with us. Give us few moments here. All right. All right, welcome. Thank you for your patience. Welcome back. Once again, this is Ang Artimo, episode 9, entitled APRV from Initiation to Clinical Application. And for today's episode, we still have Miss Rizalina Lopez, Miss Riza Lopez from Kingdom of Saudi Arabia, our clinical educator. She will be presenting this topic here. Uh, Okay, if you guys have any questions at any point, please feel free to ask question on the comment section. We will get your question. And thank you for watching with us today and continue to support our channel. Please, Miss Riza, take it away.
Hi, good morning, everyone. Thanks for inviting me to give you a short talk about APRV from initiation to clinical application. So let's do it now.
Go ahead po.
So it is said that 10% of those patients admitted in the ICU develop ARDS, and then with a mortality rate of about 35 to 45%. So there are a lot of studies that have been conducted that supporting this claim. Actually, one of this was conducted way back 2016, wherein 50 countries all over the world were subjected on this study. And then they tried to find out the incidence of ARDS among those patients admitted in the ICU. And then you will be surprised that around 80% of those who develop who had an ARDS, who had an ARDS developed this one only for a matter of the first 48 hours. So, I mean to say, just 2 days stay in the just 2 days state admission, they had this ARDS, and then majority of them were mechanically ventilated. So, as an RT, we all know that once the patient is already hooked on the mechanical ventilation, this will impose a lot of problems, such as ventilator-associated lung injury, inferior gas distribution, as well as the fact that there is a lot of asynchrony that is happening here. So, once the patient had asynchrony, so how are we responding? So, always they respond by what? They will give sedation to the patient. So once they give sedation to the patient, it will, what will happen then? It will cause some diaphragmatic immobility, and then the length of stay will prolong, as well as the cost, and uh, not to mention the incidence of ventilator associated pneumonia. So, having said so, a lot of studies were then being conducted in order to come up with what management should we do once we how to tackle this ARDS. So one of these was then conducted or formulated way back 2019, wherein you will see as the PF ratio gets what it calls one once the PF ratio worsens. So the same goes with our management. And as we all know, artists, we always come up with what strategy like low tidal volume, and then to be compensated by increasing the respiratory rate, and then the PIP starting from 5, it goes up and up and up until sometimes it even reach around 16, 18. So depending on your hospital protocol, and then even sometimes in giving neuromuscular block, giving sedation to this patient, and then if the PF ratio even worsens, let us say going to the severe. So discussion about whether are we going to start ECMO for this patient. So as you can see, a lot of problems we are encountering once we are dealing with patients with ARDS. So the problem now with the artists is the problem now for us. The challenge for the artist is actually always to keep the alveoli open. And how are we going to do this? So if you will review your pressure volume curve, we always want to ventilate our patient on this steep portion. So why? Because we all know that ventilating our patient on this steep portion of the pressure volume curve, this is what we know as the optimal compliance. We don't want to ventilate patient at this level, because at this level the alveoli are very sick. So we need a lot of pressure in order to open up those alveoli. And at the same time, we don't want even to over distend, or we don't want to ventilate the patient at this point, wherein we all know that if we reach this point, the alveoli are already hyperinflated, so less like more likely we will end up with barotrauma. So our main goal here is actually to keep ventilating the patient at this steep point of the pressure volume curve. So uh, in the hospital, we have different we have different modes of ventilation, conventional modes of ventilation like the PRVC, like the pressure control, like the VCAC, and so forth. And so we always think like, okay, what is APRV? Can I use APRV? We always think that, okay, APRV will be what? Will be the rescue mode of ventilation whenever we are really facing patients wherein we are having problem with oxygenation as well as carbon dioxide. So we always think that APRV will be the last to be considered. But actually, no, no. There are actually studies wherein we can even apply APRV as our initial mode of ventilation, aside from our rescue mode. So later, as I go through my presentation, you will understand what I'm trying to tell you. And by the way, if you think that APRV is a very new mode of ventilation, actually it's not. Tracing the history of APRV, it was first introduced in 1987 by Jones and Stock, and then in year 2005, Habashi and his colleagues came up with what they call the TCAV protocol of APRV. So if you would ask me, what is TCAV? TCAV means time-controlled assisted adaptive ventilation. So if you will look at it, time control, what does he means about time control? So if you will look at, having said so, the parameters of the APRV, we have the T high, the T low, the P high, and so forth. So they are giving emphasis with the use of time. Okay, having patient on this specific pressure and then prolonging, okay, make use of time in order to recruit the lung. So as I go on my presentation, I will explain more about this. And so in the same year, 2005, this is what I'm trying to tell you. So APRV is not just used as a rescue mode. APRV is also used now as a primary mode. So at the first time that you have detected the ARDS, you can easily use APRV. Or let us say, for example, a patient who just came out of the OR and then developed some atelectasis. So you can even think of using APRV. So APRV is not just only for the ARDS right now. So you can use this one again and again and again as an initial mode of ventilation. So from 2005, 2013, and 2019, still, there's a lot of studies that are showing that APRV is a very good mode of ventilation. So the first meta-analysis was conducted way back in 2019 by Carcetti, and then they found out that the APRV mode will lessen the time of hospitalization for the patient. So they were telling that it's really a good mode of ventilation. When again, I will repeat, when we know how to properly manage, when we know how to properly set the parameters of APRV. So let me continue. So what is APRV? APRV means airway pressure release ventilation. So what I have mentioned a while ago, it was first introduced in 1987 by Jones and Stock. So APRV is just similar as your CPAP. So we all know that the CPAP, the patient will be breathing at the continuous positive pressure, a single continuous positive pressure. Here, the patient will be breathing spontaneously. So APRV is something like this. So patient will be breathing spontaneously at the CPAP level, but the difference is that at a specific point of time, the pressure will drop, will release in a very brief time, and then after that, will go back again, whatever pressure you set in, and then the patient will start breathing spontaneously. So it's something like APRV, a continuous positive airway pressure with a brief releases, while allowing patient to spontaneously breathe throughout the respiratory cycle. So, Aprv settings. Okay, so Aprv settings. So over here we have first the pillow. So what does the pillow means? Pillow, pillow. Contrary to the conventional mode of ventilation, we are always setting a certain amount of PEEP. We're starting with a certain amount of PEEP of 5. And then because we all know that PEEP of 5 is a physiologic PEEP. But as the condition worsens, we tend to increase the PEEP going up and up and up, especially for those very hard to recruit alveoli. And even sometimes we end up with a PEEP of, let us say, 18, even 20. It depends upon your hospital protocol. So here in Aprv, we don't set, okay, pillow. We always keep pillow at the level of 0. But then if you will ask me, Riza, if I will maintain my pillow at 0, will there be any alveolar instability? Will it collapse? Actually, the answer is no. So as long as you know how to properly manage your T low, I mean your time low, it wouldn't happen. So later, as I discuss it more further, I will explain it. Okay, so but the idea here is always to keep your P low at 0. Okay, actually, studies even tells us that if you put numbers on P low, the more you will accumulate carbon dioxide. Okay, so it won't happen again if you only know how to properly set your T low, for which I will teach you later on how to do that. Next is your P high. So what is P high? So P high, this is the amount of pressure that we want to reach in. Okay, this is the amount of pressure that this is this is the amount of pressure that we are setting, and then we wanted the patient to be breathing on this level. Actually, this P high, we are aiming the steep portion of the volume of the pressure volume curve that I have mentioned a while ago. Okay, so we want this is between the region of this is between FRC, but not reaching your total lung capacity, because we believe if we ventilate this patient at this point, then we will maximize everything. Or I mean, the alveoli, it's easily been recruited. Okay, so we are targeting this P high, and if you will use Aprv as an initial mode of ventilation for those patients, let us say, like what I've told you, just came out having some atelectasis, and then you will notice that there will be an immediate recruitment of the lung. So once you have an immediate recruitment of the lung, then you have to guard your lung, you have to guard the alveoli, you have to guard what is happening with the alveoli. So what I'm trying to tell here is that you have to look at your chest X-ray. Am I hyperinflating the lung? So how are we going to know this? Looking at your chest X-ray. So understand where is the maximum where's the maximum curvature of your diaphragm now, because we all know that hyperinflation, it will the way on how to detect hyperinflation is there will be a flattening of the diaphragm. So try to count on the number of ribs. We all know that we should see around 8 to 9 posterior ribs. But then once we go above this number, so think, am I now hyperinflating the lung? Is there any possibility of barotrauma? So again, when setting your T high, just make sure that you are you know how to properly set it, not to the point of hyperinflating. And then next is what we call the T low. The T low is the release time. This is how this is in control. This is in control of the amount of pressure that we want to release, the amount of volume that we want to release. Okay. So by the way, another thing that I want to make mention about the T high is also in control of what we call as the bulk rate. So this is also in control of the alveolar ventilation, and I think so forth. Okay, so I will explain more further. So here, this is a Jager ventilator. I just want to show you how it works. Okay, so this is the P high. Okay, P high, and then this is now your T high. So the patient is now ventilating at this. Okay, and then at this certain level, the pressure will go down. It will be released, and then it will maintain at whatever T low you set, and then again go up to your P high, and then again allow the patient to breathe on this portion. So, looking at this slide, we have here the this is the P high going up, and then this is our T high. This is where the patient will be breathing. So this is what we call as the CPAP phase. So this is the summation of your P high plus your T high. Okay, while the release phase is actually the summation of your P low and T low, which is happening from here, and then it will last until here. Okay, so this is your release phase. Now, here is it. We want the patient to be breathing spontaneously. And if you will look at this gray color, these are the spontaneous breath done by the patient. Okay, so maybe you will be wondering, Riza, I have a sick patient, but then why should I ask my patient to have spontaneous ventilation? Why should I ask my patient to breathe spontaneously? We are doing this because of different reasons. First, we all know, okay, reduction in the use of sedation. So if you will allow your patient to breathe spontaneously, they will have the liberty to do it by themselves. They are in control of their ventilation. So we will there's no such thing as what a synchronization with the machine. Another thing, if we will not sedate the patient, then we will prevent the diaphragm to be atrophied or to go for atrophy. And another thing in here is that, as you know, APRV it mimics the work of negative pressure ventilation. So it is much better to pull in, okay, the volume rather than to be pushed in, like what is happening in a positive pressure ventilation. Okay, so if we are going to do this, having the liberty to control our ventilation with the diaphragm working, so the hemodynamic profile improves. So something like, okay, uh, we all know that in positive pressure ventilation, uh, we have to guard this because it will what it affects the heart itself in a way, like the venous return and the decrease in the cardiac output. But then if we are doing it spontaneously, this one will be minimized, or it will never happen. Okay, so spontaneous ventilation again, the beauty in it is that all of those things that I have mentioned will be prevented. So a while ago, I have made mention about the APRV parameters, for which we have the P high, the T high, the P low, and the T low. So let us go one after each other. Okay. So the P high. So the P high, as what I've told you a while ago, this is the amount of pressure that we want we want to target, that we want to achieve. This is where we want the lung to be ventilated. Okay, so the P high, as what I have told you, this is we want the patient to be breathing at this level. Okay, again at this level. Okay, so this is between your FRC, but then not reaching your total lung capacity. We don't want the patient to be breathing over here, because we all know that over here, like what I have mentioned a while ago, these are the region wherein we needed a lot of pressure in order to open up the atelectatic lung. Okay, it's just like a balloon, just like a deflated balloon. So whenever you have a deflated balloon and you want to inflate it, at first, if you try at the first few part of it, you will try to what exert a lot of effort to open it up. But once you reach the certain level, like, okay, you will feel that, okay, there's no more resistance, I can open it up. So it's actually happening over here. So the ventilation, okay, ventilating the patient is not hard at this point. It's not hard at this point. Okay, so this is what we want to achieve with P high. So how are we going to set our P high? So it depends. It depends. So as you can see over here, if your patient, if you are transfer or shifting your patient from a conventional mode of ventilation like the volume control, you have to get your plateau pressure. You have to get your plateau pressure, and then whatever the plateau pressure, that will be your P high. And then if you are using the pressure control, this is set according to your PIP. If you are then using your high freq, okay, so this is the mean pressure, then you have to add plus two to 4 centimeter of water. So now, how do I know if I'm giving too high pressure to my patient, or how do I know if my pressure high setting is not enough for my patient? So now you have to understand, you have to look at your graphics. So when I say the graphics, you have to see your pressure waveform, then you have to see your flow waveform. So over here, this is what we want to achieve. So this is at your CPAP phase, okay, the P high. So over here, you will see the sinusoid. I mean, you will see the patient is breathing. Okay, and then over here, this is the corresponding. So the grayish color that you can see right now are all spontaneous breath done by the patient. So this is sinusoidal, if you will take a look at. So this is what the kind of waveform that we want to achieve. But then if you are giving or setting your P high too high, what uh, too high than what the patient needs. So this is what will happen. Okay, so there will be a shifting of the waveform. Okay, from the sinusoidal, you will see this one a little bit longer because the patient is now trying to exhale more. Okay, because there's a lot of trapped in gas there. So he wants to get rid of this because there's a lot of pressure that you have given him. So the patient will be struggling. So this is one indication. If you will look at your graphics, then take a look at this one. So this is not what we want to the patient. And if this is what is happening to the patient, then you have to think of decreasing your P high. P high by how much? So studies have made mention that you have to decrease it by 2 to 3 centimeter of water, and then review your chest X-ray. Take a look. Okay, what happens to the diaphragm? Is it already flattened? How many ribs can you see? Okay, so this is something that is noteworthy. As you can see, artists, we're not just good when it comes to the numbers. We're not just good when it comes, okay, I have here my settings for my ventilator, and then I have to compare it with my measured values. Yes, we can do it, but then try to maximize everything that you can see from the ventilator. The scalar waveform, the loops in the graphics can tell you a lot of things about the patient. So focus on this one. Okay? So what about if your P high is not enough than what your patients need? So how does it look like in the graphic? So take a look at this one. So here you will see that there is a peak. So meaning to say the patient is trying to take a deep breath in order to what? To sustain, in order to get more of what he needs. Again, what we want is this waveform, the sinusoidal. But then since you are giving low pressure to the patient, that what he needs, he will struggle. He will try to pull more air to the patient. He will try to pull more air. And so this is what will happen. Okay? So again, try to maximize the graphics. We don't want this. We don't want this. What we want is the sinusoidal, which is like this. So I hope it's clear. Now, uh, uh, on my previous slides, I have made mention that nowadays, APRV is not just used as a rescue mode. Unlike before, we will say, okay, I will now put my patient on APRV because I already maximized everything from volume control. I already transferred my patient to pressure control, and yet with the high PIP still. There's nothing. There's nothing. So it's now time for me to shift my patient to APRV because this is the last mode that I can take. Actually, nowadays, yes, we can still use this one as a rescue mode, but then we can now even use this one as an initial, okay, initial mode of ventilation. So, to whom can we use this one? Again, as what I have mentioned a while ago, if you have some atelectatic problem over there, okay, normal lung, but then after surgery, patient got have this atelectasis, then you can think, why not? Okay, why not? I can use APRV as my initial mode. So how are you going to choose? Okay, how are you going to choose what is the pressure that are you going to give to your patient if you are going to use this one as what as an initial mode? So over here, it was suggested, okay, that if you are going to use this one as an initial mode, okay, using again the time controlled adaptive ventilation, which was formulated by Habashi and his colleagues, they are recommending, okay, you can ventilate, you can set your P high between 20 to 35 centimeter water, okay, but then, okay, question is, Riza, can I go more than 35? Okay, because we all know that, okay, we always set a pressure limit at 35 because we don't want to explode the lung. Okay, this is our something like, okay, I don't want to go more than this because I will end up with a lot of problem. But actually, with their study, Habashi colleagues study, they say that you can even, okay, set your P high more than 35 centimeter of water. So to whom are you going to give this one? Okay, to those patients with decreased thoracic and abdominal compliance. So what am I trying to tell you here? Okay, in their study, okay, this is how is it. Okay, so if your patient has a normal lung, okay, and by the way, I just want to clear this out, okay, so your lung, okay, so your lung can what? Can open up, okay, can open up normally, okay, if the surrounding structure is not giving a lot of problem with them, okay, the resistance is not that high. You have to imagine that you don't have, it's not only the alveoli that is affecting, but there's a lot of structure that is affecting the movement of your alveoli, the movement of your lung. So you have to consider what? The thoracic cage, the abdominal cavity. So are these limiting the movement of the lung? So if you don't have any problem on those, let us say for example, okay, you are giving 20 centimeter of water as your P high, and then those resisting factors are not more than what you are giving. Say then you will never have a problem, okay, opening up the alveoli itself, because what you're giving is higher than those resistance. But then in some cases we're in, let us say for example for this patient, okay, so this patient got a very big tummy, okay, so very big, the abdominal is actually what, it's patient is obese, there's abdominal distension, so it is keeping, okay, it is actually keeping the lung up, and then it will resist the movement of your diaphragm to go down. And some more, there's a lot of other factors that I have told you. Okay, what about the thoracic? So let us say, for example, all of those resisting factor, okay, is more than what you are giving. So let us say, for example, you are just giving 20 centimeter of water, but then all those resisting factors are more than what you are trying to give. Do you think you will open up the alveoli? No, it wouldn't, because the resisting factors are even greater than what you are giving, isn't it? So according to Habashi and their colleagues, they made mention that yes, you can give uh, P high more than 35 centimeter of water for those patients with decreased thoracic and abdominal compliance. Okay, but then what about if we're going to use this APRV as an initial? Okay, when shifting your patient from other modes of mechanical ventilation. So I think I have made mention this a while ago, right? So if you have your patient on the volume control, take the plateau pressure. If you have your patient previously on the pressure control, then take the peak pressure. Then over here, we have the dual targeted mode, which is your PRVC. So again, it was said that take the peak pressure because it is almost near than your compared to the plateau pressure. But then sometimes we will have some problem with a dual targeted mode of ventilation, like for example, okay, so I don't know if you encounter this situation wherein you are ventilating a patient, let us say, with 400 mils of 400 mils tidal volume, and then all of the sudden you have noticed that the exhaled tidal volume is around 700 or 800. Then you might be wondering what is happening. Why is it that the exhaled volume is greater than what I set? And then if you will look at the peak pressure, then you will notice that the peak pressure is only around 13, only around 12. So what's wrong? What's wrong with my patient? Okay, and then you will see your patient struggling. Okay, and then if you want then to shift your patient to PRVC, you will have some problem in here now, because the peak pressure that you are seeing at this very moment is not a true reflection of what the peak pressure of your patient is. So how are you going to solve this problem? Okay, so try to take a look at your patient. Are you really giving your patient the correct amount of volume that your patient must need? If, let us say, for example, you are hypoventilating the patient, so of course, okay, what will the patient do? The patient will definitely suck in. So how are you going to solve this problem? Okay, you might consider removing or turning off your ATC at this point. Okay, and then you might even think of what increasing the volume if you want. I mean, if you want to get the plateau, or the best way is most probably try first to sedate your patient until everything calms down, and then and then measure your plateau pressure. I think that's the best way. Okay, so another here is more the high fric. Okay, although I haven't tried this, but then I saw this from their study. They said that high fric, if you want to shift your patient from high fric to to APRV, then you have to get the mean airway pressure. The only thing that you have to do is to add 2 to 4 centimeter of water above this, because over here in King Fahad, uh, it's just something like, okay, we choose whether APRV or high fric. And by the way, high fric, we always use this one for what? For the neonates. For what? For small babies. But then for APRV, we are using this one for adult patient. But then studies have made mention even that APRV can also be used for neonates as well as pediatric. It's just the settings are, of course, different than that of the adult. But then, as of my how many years of practice, we have never used this one for ventilating neonates as well as pediatrics. So we applied APRV for those adult patients. Okay, now, what about if you want to use APRV as a rescue mode? Okay, so this is what Habashi, okay, and his colleague recommends. So the same, if you are going to use APRV, okay, as a transition mode. Okay, so the same advice he gave us. Okay, so plateau pressure, the peak pressure, the mean airway pressure, it's just the same. But then, what if you want to use APRV as an initial mode? Okay, considering that this is a rescue. So mean to say the patient is really so bad. How are you going to set then your P high? So over here, they said that setting your P high here will now be based on Berlin's criterion on ARDS. So what is Berlin's definition of ARDS? So Berlin's definition, this was published in JAMA 2012. So over here, they have made mention specifically. Okay, so mild ARDS is between a PF ratio, yeah, a PF ratio of 200 to 300. Okay, so what is PF ratio? How are you going to compute the PF ratio? PF ratio, P means PaO2, which you can get from your arterial blood test, and the FiO2 is definitely your setting for the oxygen. So if you get the PF ratio of between 200 to 300, and with the PEEP of equal or more than 5 centimeter water, then having said so that 1 week of known clinical insult, worsening respiratory symptoms, and then with the chest x-ray showing bilateral opacity. So what do I mean by the bilateral opacity? So I just want to make this clear. When you are dealing with chest x-ray, you have to understand that when you say opacity, this is whiteness of the lung. So when you say opacity, the lung is getting dense. Why is it getting worse? Why is it changing from radiolucent, which is black in color, and then it will change to white to become becoming white now, to becoming opacified. So this is because of what, some fluids over there, infection, in spewed secretion, some what it calls cells over there, or everything that will contribute into a lung getting dense. So here they have made mention that chest imaging, there is a bilateral opacity, meaning to say both lung are now getting white. So, but then these bilateral opacities are not fully explained either by effusion or either by collapse or even by the presence of nodule. And the origin of edema is not well explained. So they say that if you get a PF ratio between 200 to less than, I mean, from 200 to 300, again with a CPAP level of equal or more than 5 centimeter of water, then we categorize this ARDS to be mild. And if you have a mild, okay, if your patient is having this mild ARDS, then he suggests, okay, that you will start your P high between 20 to 24 centimeter of water. Okay, but what about if you have this? If you have the PF ratio of between from 200 down to 100, okay, from 100 to 200. So then again, with a PEEP of equal or more than 5 centimeter water, this is considered as a mild ARDS according to Berlin's definition. So they suggest that you will start to give to set your P high between 25 to 29 centimeter of water. But what if your patients now is so severe? So how severe it is? So if you will look at the Berlin's definition, this is your PF ratio now is falling less than 100 with a PIP of equal or more than 5 centimeter of water. Then of course you have to give higher pressure. So they are suggesting that here you will start your P high from 26 to 30 centimeter of water. By the way, what I am trying to tell you are just initial. Okay, these are just initial setting. So the 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 adjustment on your setting will come once you have taken your blood gas. Are you going to increase or whatever? Okay, so these are just initial settings. Okay, so now, so this is about the P high. Okay, now uh here, what about the T high? So a while ago, I have made mention that the T high is the is the the time. Okay, that this is the point wherein you are. This is the CPAP. This is the CPAP. The time wherein you will allow your patient to do spontaneous breath. Okay, so this is your T high. By the way, your T high, like what I have mentioned a while ago, you have the control on your bulk rate. You have the control on your alveolar ventilation. Okay, so this is where the recruitment actually is happening with your T high. Okay, so here you want the patient to be breathing on this level. Okay, no, you want the patient to be breathing at this duration. The level is more on the P high, but then duration of your breathing, this is what the T high means. Okay, so here in adult, we are aiming the CPAP phase, this one, to be more than 90% of your total cycle time. So what is cycle time? So how are you going to get your total cycle time? So over here, you have your T high of 5.5 second. And let us say, for example, you set your T low at zero point 0.5. So you have to sum this up. So 60 divided by then 6. So this will give you 10. Okay. So over here now, what you are going to do, okay, you have to get, like what I have told you, the CPAP duration that we are aiming is how much? 90%, okay, to have your recruitment of the alveoli. So how are you going to get it, okay? So now over here, you have your T high of 5 over 5.5 and then divide it by the summation of your T high and then your T low. So this will give you a cycle time of 92%, for which we are what? We are targeting. Okay, we have now. So because this is more than that what we want. Okay, so sorry for this. So I will show you the importance of time. That is why Habashi they made mention like APRV with TCAV, okay, TCAV, time controlled adaptive ventilation. I have here a video which I want to show to you. Okay, with the same amount of pressure, okay, and then prolonging the inspiratory time. How can it help, okay, to recruit the lung? Okay, so I will divide this into two. First, showing to you at 1 second. And then after 1 second, I will try to prolong my inspiratory time to, let us say, 4 or 5 of a second. And then I want you to understand how what will be the difference when it comes to alveolar recruitment. Okay. So by the way, this is a rat's lung. Okay, so the yellowish that you can see from here, these are actually alveoli which are inflated. Okay, and by the way, on ARDS, you have to understand that we are dealing with heterogeneous lung. So mean to say there are some lungs which are still working. Okay, which we can say, or we call as the baby alveoli. So there are still portion of the alveoli which are working well. Some might be collapsed. So we are there's a lot of things that is happening, okay, when we are dealing with an ARDs. So that's why we call this one as a heterogeneous lung. Okay, so anyhow, let me run. Okay, so let us say I'm giving a specific pressure. Okay, same amount of pressure. Okay, now I'm running this one at 1 second. Okay, class. So as you can see, I was able to recruit some of the lung, some of the alveoli. Okay, it opens up. Okay, but what if with the same amount of pressure, I will try to prolong my inspiratory time? What will happen? Okay, so take a look at 4 seconds. Okay, so that's it. Take a look at what had happened. Okay, with the same amount of pressure, but then prolonging your inspiratory time, this will allow recruitment of more alveoli. Okay, so this is what they are trying to tell us when it comes to APRV. APRV helps you a lot. Okay, helps a lot when it comes to recruitment of the lung. Okay, so next, how how will I set my T high? Okay, setting your T high. Habashi colleagues have said, okay, you can set it from 4 to 6 of a second. Okay, but is this applicable for all patients? Okay, I should say not not all. Why? Because this is for a patient who has what? Normal lung and then who has just developed atelectasis. Okay, so if you have some patients like this, then you can let the patient breathe spontaneously at this certain amount or at this duration of T high. But the question is, what about for those patients uh, who has a very stiff lung? Okay, like in COVID. Okay, like in COVID. So this patient, am I going to allow them to do spontaneous breath? Okay, so I want this to be clear enough. So when we say about spontaneous breath, okay, Are you going to keep a patient who is breathing at the rate of 30 to 40, okay, allowing them still to breathe at this rate? Do you think it will benefit them? Actually, no. Okay, if you have a patient who is breathing so hard, tachypnic at 30 to 40, then the idea here is no, you should rest the patient. You should rest the patient, okay? You should rest the patient. And so it is now contradicting the APRV because a while ago I have told you, right, that patient on APRV, they should be spontaneously breathing. Yes, they should be spontaneously breathing. But the question is, with the patient very tachypnic, are you going to keep them still breathing spontaneously? Or are you just going to injure the lungs some more? So Habashi and et al. And their colleague have said, okay, in patients with COVID-19, they recommend, okay, shortening the T high considerably to improve bulk ventilation. So a while ago, if I mentioned about the 4 to 6, on COVID-19 patients, okay, they recommend, okay, it should be set between 1 to 3 of a second, okay, 1 to 3 of the second. So the question here now, okay, and the question here now is that, okay, if you are the idea here is to for the ventilator to take control of the patient's to take control of the patient's breathing. Okay, so you will now try to what, to rest the patient. You will try now to rest the patient. Okay, then but then the question is, how am I going to set it? Okay, how will I know how to set it? Okay, so over here now, they had come up with a formula like the 60 divided by the current rate. Okay, what your patient is doing, what is your setting on the ventilator? Okay, so for example, you are setting the ventilator, let us say at 20, 26 or 28. So 60 divided by 28. So whatever the quotient is, and then you have to subtract now your T low, for which I will mention later how much you should set your T low. Okay, so that will be now your uh, the duration of your T high. Okay, so over here I have an example like, okay, if let us say for example over here I have your rate of 20. So 60 divided by 20 is equivalent to 3. And then if I set my T low at at 0.5 second, then the rescue T high will be 2.5. Okay, so if you will notice, this will you are putting your your duration, okay, between this number. Okay, so again, the number that I have made mention a while ago, 4 to 6, this is for the patient who has a normal lung and then just develop atelectasis for some reasons. But then the level of air, the level of the severity is not that bad if compared to what we are encountering now with the COVID patients. Okay, so let me move on. Okay, what about the pillow? Okay, so pillow. What about the pillow? On conventional modes of ventilation, we start always putting your PIP at the level of 5, isn't it? Because we all believe that PIP of 5, this is the physiologic PIP of the patient. Okay, and then we tend to increase the PIP as the level of the sorry, as the level of the as the condition worsens. In APRV, this is not the case. Sorry. On APRV, we are setting the pillow at always at 0, always at 0 centimeter of water. Okay, so the question is, Riza, we want to recruit the lungs. So if I will put my pillow at 0, will it cause the recruitment? Is it the same as the PIP that I'm setting at the conventional mode of ventilation? Actually, no. You don't have to be afraid. So as long as you are properly setting your T low, then this wouldn't happen because the T low will have a full control on how much pressure are you releasing, how much volume are you releasing. So always put your P low at 0 unless there is really a very, very huge need for you to increase your pillow. Otherwise, it is always recommended that the pillow should be set at 0 centimeter of water. So another reason why we are doing it is because of we don't want we want, okay, expiratory resistance always to go down. Okay, as you can see over here, this is what is happening. Okay, so the patient is breathing at the CPAP level. Okay, so diffusion of gases is happening here. Then once we come up with, okay, so this is now the time for you to release the pressure. Okay, after completing your T high, so this is now time to release the pressure. So we want, okay, the bulk of this carbon dioxide to get out. But then what will happen? Let us say, for example, you put the PIP, okay, the PIP, you put P low, let us say at 5, you put P low at, let us say, of 10. So what will happen here? You are adding resistance, okay, you are adding resistance here. So do you think the carbon dioxide that is accumulating at the limb of the ventilator will go out? Of course, no. Okay. So, by the way, this is the expiratory limb, by the way. So, what will happen here? No, because you are adding resistance. So, the more carbon dioxide will accumulate, and so the higher the PCO2. So, again, I will emphasize this one. Never ever, okay, put any number for your pillow. Maintain it at 0. Nothing to worry about the recruitment of the lung. As long as you know how to properly set your T-low, then you will be in a safe side. Okay? Okay? So I think I made it clear. So if you will look at here, okay, both using APRV as an initial transitioning your patient from another mode, or as an initial mode, or even for a rescue, okay, rescue ventilation, still they are recommending pillow to be at 0. Okay, so I think I made it clear. Okay, now what about the T-low? Okay, the T-low is the release time. Okay, so this is the summation of your pill. I mean the release time itself is the summation of your pillow plus your T-low. So the T-low here, okay, this is in control of how much pressure are you going to release. Okay, and then it is recommended. Okay, again, this is, I will make emphasis on this because this is the trick when it comes to setting your APRV. The success also of your APRV is how good are you when you are setting your T low. Because if you will set it longer than what the patients did, then that is when you will develop alveolar the recruitment. Okay, so over here in T low, the target is at an end expiratory flow rate of 75% of the peak expiratory flow rate. So, Riza, what is that? What do you mean by 70 end expiratory flow rate of 75% of the peak expiratory flow rate? So again, make use of the graphics. Okay, so what am I trying to talk? What am I trying to tell you? Okay, so over here, if you will look, okay, this is the flow waveform in the monitor. So the one on top is the inspiration, and the one below is the expiration. So this is the beginning of expiration, and then this is the end of expiration. So in the conventional mode of ventilation, as much as possible, we want this to go back to the baseline 0, because we don't want any auto pipping. We don't want to trap gas. So as much as possible, bring it back to 0. So how will you know if you have auto pipping over here? It's easy, because here the curve will not go back to baseline 0, and then another initiation of inspiration will happen. So that is for the conventional. Okay, so we want always to keep it at 0. But on APRB, this is not the case. Okay, we want to terminate expiratory flow. Okay, expiratory flow at a certain percentage. So we want to keep it. We want to keep it. And how much? We have made mention that it should be 75% of your peak expiratory flow. So what am I trying to tell you? Where is the peak expiratory flow? Okay, so over here, okay, uh, let me go back. Okay, over here. So here, this is the expiratory. Okay, this is the expiratory. Sorry. So you will see here, this is the inspiratory on top, and then this is the expiratory below. So try to look at the point over here, and then try to go back here. Okay, so you will see here 100. Okay, so you will think that this point is your peak expiratory flow, right? Because this is the highest peak that you can reach during the expiratory phase. But actually, this is not your peak flow. Okay, this is not the peak flow. The peak flow is actually over here. Okay, the peak flow is over here. So take a look at the angle. Okay, take a look at this angle. Okay, so just try to to draw a line. Okay, so here, this is your peak expiratory flow. Okay, so this is the peak expiratory flow. So now we want to compare. And what about this 30? This is the termination of your flow. Okay, so this termination of your flow over here, you are in control depending on how much is your set T low. Okay, I will explain it a bit later. Okay, so just let allow me to move forward. Okay, now if let us say for example I terminate this one at point, let us say point 60. Okay, point 60, and then it so happened that you have to compare this 30 with your 55. So here you'll be needing your calculator. If you are good in math, then good for you. So here, what I'm trying to tell you here, 30 divided by 55, it will give you 54. Okay, so this is around 55. So meaning to say, 30 is 55% of your peak expiratory flow rate of 55. And if you will again recall the suggestion that they have given us, it should be 75% of your peak expiratory flow. So for that reason, since the 30 here, which I set at let us say 0.50, then I have to decrease it some more. Okay, I have to rotate it some more. And then now try again to compute. You should reach 75% of your peak expiratory flow. Okay, so um, here you need to understand, okay, where is really the peak expiratory flow. So don't be confused. Okay, the moment you see something like this, don't ever think that this is your peak expiratory flow. Otherwise, what you will do here now is what? You will take the 30 and then divide it by here the 97, and it will give you a wrong answer. So that is why you will have problem on what? Recruiting the lung. So you have your patient already there for how many days, and yet the lung is still unrecruitable because what you said is wrong. This is not actually the 75%. This is not actually even the peak expiratory flow. And then if you will ask me, and so Riza, what is this? What is this? If you are telling me that this is not the peak flow, and so what is this? Actually, this is the with your patient. Maybe the patient got a lot of secretions over there, or maybe your HME is very wet, or there is some obstruction that is ongoing. This is causing the peaking, okay? But this is not the peak expiratory flow, okay? So you have to understand really very well, okay? Try to identify where is the peak expiratory flow, okay? So let me move forward. Okay, so this is what I'm trying to tell you, okay? Our usual target here is an end expiratory flow rate of 75% of the peak expiratory flow rate. So let us say, for example, okay, over here, okay, so the peak expiratory flow rate here, this is for sure your PEFR, okay, because over here it goes up, okay, it tries to goes up. Okay, so this is your peak expiratory flow. So over here, let us say, for example, this is the peak expiratory flow is at 100. Okay, and then you set your T low at 0.7, okay? And then at 0.7, okay, you terminate it at 20 at you set your T low at 0.7, thus giving you 25%. So where does this 25%? This 25% is actually the 25% of your peak expiratory flow. So are we targeting what we want? Again, we want 75%. So what are you going to do now? 25% is not good. Why? Because if you set at 25%, which is far from our target of 75%, then there will be what? The recruitment of the lung, the recruitment of the alveoli. So you will see. Although, okay, our target here, by the way, is to what? To recruit the lung. But then you are giving so much time. Okay, so again, alveoli will collapse, and then you will end up again and again and again, and then you'll be wondering why is it's not improving at all, because you set it incorrectly. So what are you going to do now? Then you have to adjust it. Okay, so let us say, for example, okay, Riza, since this is 25% of my peak expiratory flow, so I will try to decrease my T low. So I will decrease at 0.6. So after decreasing at 0.6, okay, I end up at how much? Here, right, at 50. And then this 50 is actually the 50% of your peak expiratory flow of 100. Still you're far from the 75%, okay? So again, what are you going to do? Try again to decrease the T low until you reach to this level, okay? So over here, 75. So I will end up here because this is what I want, okay? So the release of the pressure or the release of gas will end up at this point, okay? End up, so this is the release, and then once it reaches here, then again, inspiration goes up. This is what I'm trying to tell you with how you are going to target, okay? How are you going to set your T low? Again, T low and expiratory flow rate of 75% of the peak expiratory flow rate. So use the flow waveform in your ventilator graphics. Okay, so over here, can you spot it? Can you spot where is the peak expiratory flow? Again, this is not the peak expiratory flow, okay? So this is resistance. Where's the peak expiratory flow? This is happening over here, okay? What about this? Yes, this is it, okay? So as you can see, there's no such thing as a needle-like, okay? So setting your, what about your T low? How long setting the T low, how long the pressure release, how long is the pressure release phase? Okay, so they said that usually it should be set between 0.2 to 0.6 second long. But again, this is just, okay, as an initial, how are you going to start with, okay? Between this range. But again, once you are there, then it is suggested for you guys to compute for the 75% of your, like what I have mentioned a while ago. With an exemption, if you are dealing with a patient on COPD. So Habashi and their colleagues have made mention that you can set it at 50%, okay? And expiratory flow, 50% of your PFR. This is can be allowed for a COPD patient because we want, okay, of course, carbon dioxide to get out longer. Okay, so over here now, setting ATC. So what is ATC? ATC is what? ATC is automatic tube compensation. So if you, by the way, what is the importance of ATC? ATC is it will augment, okay, the resistance offered by the tube. That is why if you are setting your ATC, turn it on, then you have to clearly identify what is your tube size. Okay, let us say you are using tube size of 7.5. So put it there. Tube size is 7.5, and then try to identify Okay, is this a tracheostomy or is this ETT? So if this is an ETT, then choose ETT. So now the ventilator will try to compute, okay, how much pressure will it give in order to augment the resistance imposed by the airway. Okay, so whenever you have a patient on APRV, so it is recommended to turn on your ATC at 100%. Okay, maximize your ATC. Now, maybe you might ask me, what about if I have a pressure support? Can I turn on my pressure support? So can I add some pressure support of, let us say, 5? Can I add on a pressure support, let us say, of 8 or so forth? By the way, it was advised that no, you shouldn't turn off your pressure support. Why will I not allow pressure support? As you can see, a while ago, I have made mention that your patient will be breathing at what? Spontaneously breathing at a CPAP level, right? So since your patient will be breathing on CPAP level, yeah, why not? Why not just put, okay? Why not help, okay, my patient? I'll give pressure of 5. So what's the deal with it? It's just a small number. Maybe, but then how sure are you that the 5 that you set is just a small number? You have to identify. You have to understand that the P low, I mean, sorry, the P high, our target P high is actually at the steep level of the pressure volume curve, right? So this is where we want. If I will go back, allow me to go back. Okay, okay. So we want only to ventilate your patient over here. Allow your patient to be breathing at this level. Okay, because what will happen if, let us say, for example, you add up a pressure support. Okay, so pressure support, it will give another pressure. It will give other pressures to your patient. And then we don't know if the set pressure that you have given to your patient will what? Will reach to this level. Okay? A level wherein we don't want to happen. Because if it happens that it reaches or it shoot up, what will happen is that the alveoli will be what? Hyperinflated. And once the alveoli becomes hyperinflated, you know, RT, what will happen next, right? So what will happen next is barostroma. So that is why they are suggesting, okay, they are suggesting that it's a no, 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 okay, to set pressure support, okay, on APRV. You can turn on your ATC at 100% to augment the resistance offered by your airway, but not to give a pressure support level. Okay, so just allow your patient to breathe spontaneously at whatever P high that you have set in, and that's it. Okay, so now I think I already explained the different parameters, starting with the P low, P high, T low. So let us go here now, okay? So what are you going to do? If, let us say, for example, you have a problem with hypoxemia, okay? So of course you have your FiO2, so you can first, okay, work on your FiO2. But then once we are talking with the parameters, what are you going to do? First, okay, take a look, examine your T low. Are you setting your T low correctly, like what I have told you a while ago? Is it 75% of your peak expiratory flow rate? Because if this is more than 75%, then I'm telling you that you will end up with what? The recruitment of the lung. So if this happens, so you have to decrease it by 0.05 to zero point 0.1 and then try to target the 75%. Maybe you will be asking me, Riza, why are you always talking about the 75%? Is this really is this really valid? Okay, so actually, while I was watching the research done by the presentation done by by Habashi, uh, Andrew, and a lot of them. Okay, uh, according to Dr. Habashi, okay, he tried, okay, decreasing the P low, okay, let us say even let us say to 70, 65. So, but then even working on this, okay, even manipulating on this, it seems that he can't, okay, he can't what expel or remove the carbon dioxide. He can remove the carbon dioxide. So they only found out that this carbon dioxide, okay, uh, I mean the hypoxemia, okay, the hypoxemia can only be prevented if you will set, or if you will cut your peak expiratory flow rate at 75%. Okay, so nothing is happening. Okay, so just keep it at this point. Okay, 75%. Now, what if, yes, Riza, my peak flow is at 75%. So what else can I do? Okay, now you can think of, okay, what about my patient? Am I giving the correct amount of P high to my patient? Take a look at how your patient is breathing. Is your patient pulling a lot of air? Okay, so take a look at the graphics. Is there any peaking on the inspiratory phase of your peak flow? If this is what is happening, so maybe you are giving the you are not giving the sufficient amount for your patient, okay, the sufficient amount of the P high. So why don't you try to what to increase your P high by 1 to 2 centimeter, okay, by 1 to 2 centimeter. And then again, try to analyze your patient, take a look at the graphics, okay. And then if your patient you think has a lot of resistance from there, okay, some restrictive, okay, have distended abdomen, then morbidly obese, and then you can even think, okay, do not limit it at 30 centimeter of water, you can even go up to 35 centimeter, okay. So you have to understand this point, okay. And then you can even try to what, consider increasing the T high. T high by how much? Try to increase it by 0.5 to 1 of the second. If you will recall the video that I have shown you a while ago, that if you will try to extend the T high, so the more time you are giving for the alveoli to be recruited, okay? So you can think it this way. And the last resort, the last option that you can think of, if you have a patient on hypoxemia, is to increase the P low, okay, by 1 or 2 centimeter, okay, by 1 or 2 centimeter. That would be the last option. But then, as much as possible, no, no for this, okay. So, okay. So what about for hypercapnia? Okay, CO2 problem. Okay, for hypercapnia, so we have what we call this the permissive hypercapnia, right? So depending on the doctor, depending on your institution, what is your acceptable? Okay, the pH. So once you are dealing with very severely ARDS, so are you going to be very idealistic with 7.35 to 7.45? Of course, no, because if we will do it, you will see all your parameters going up, and then, well, I don't think it is also what do you call this one achievable at at this point. Okay, so you will be struggling. So over here, if you have a patient on ARDS, we are tolerating permissive hypercapnia even down to a pH of 7 point equal, okay, or higher than 7.15. Okay, so before you try to reduce the PaCO2, think carefully whether you truly need this or not at all. Okay, if your patient is tolerating high PaCO2 and is doing well clinically, the best thing to do is just to leave your patient alone. Okay, so okay, so what else? So here now, if really you need to work with your CO2 or lowering down your CO2, what are the interventions that you can do? Okay, here. So so I have here the list of what you can do to reduce the carbon dioxide. Okay, but doing this may cause some problem, being less lung protective. Okay, so first understand, okay, since we are promoting spontaneous ventilation to your patient, okay, so are you sedating your patient so much? Okay, is your patient breathing still spontaneously? Okay, then if patient is really knocked down with your sedation, you can even lighten, try to consider bringing down your sedation a little bit to encourage the patient to do spontaneous ventilation. Okay, so if the patient is doing this, then what's next? So you can even consider increasing the P high, okay, and the T high simultaneously. So why? Because again, okay, here you are promoting what? There is a what? Alveolar ventilation, okay? So you can think of doing this, okay? So another point is that you can even think to lengthen, okay, your T low to 0.5, even to 1, with an increment up to the time wherein you reach your 50% of your PDFR. So this is a little bit contradicting now, okay, with what we are trying to tell of 7.75%. So you will only do this in worst to worst come scenario. But then as much as possible, again, please don't do this, okay? So just limit it to 75%, okay? And then you can, what else? You can even think to, let me show you, okay? Over here, okay? So again, going back, P high, 1 to 2 centimeter, okay? Uh, if you are dealing with a normal lateral, okay, as long as your P high is equal or less than 30 centimeter, but if morbidly obese, again, you have the liberty to go up even to 35 centimeter, okay, and even up, okay. So you can do a T high manipulation, but then going to your T high manipulation, this is a double-edged sword. So what am I trying to tell here? So here, increasing the T high, okay, increasing the T high, like what I have mentioned a while ago, this will improve recruitment, isn't it? This will improve recruitment because the surface area will expand, okay? So, but then, and by the way, as the lung recruit, so it will improve the carbon dioxide clearance. But chances are the recruitment will happen at the same time. Okay, now what about reducing your T high? So reduction of your T high can be, okay? Why? Because if you reduce your T high, it will increase what we call as the bulk rate. Okay, so it will increase the frequency of releases. Okay, so it will the frequency of pressure release. Okay, will increase, thereby increasing your minute ventilation. Okay, you can even what else? Here, like what I had mentioned a while ago, you may even think of what increasing your TILO, but then really I don't suggest it. Okay, but then worst comes to worst, then you can even think of it. But then this is maybe one of the last resort that you might think of. Okay, so hypocapnia. So what about if your patient is having hypocapnia? So hypocapnia may be an indication that the patient is ready for weaning. Okay, so how are you going to manage hypocapnia? So here now, since we are going for weaning, so you can even think of decreasing your P high and increasing your T high, decreasing your T low. Uh, here, okay. Let us go to the weaning of APRV. So how would you know that if your patient is already weanable from APRV? So you will see, you have to check for the patient's readiness to be weaned off. First, the patient is breathing spontaneously. And what do I mean by spontaneous? It's a decent respiratory rate. It's not that the patient will be breathing at 30 or 40. Then you will say that, okay, my patient can be weaned off because he's breathing at this rate. No, okay, at a reasonable rate, maybe around 10 to 25 as they suggest, breaths per minute, okay? So patient should be calm, and then patient should be conscious, okay? So you can what else? So for pain control, you can consider a little adding a ketamine just to for the pain control, okay? To allow weaning if you're giving some sedations to your patient, but really not giving very high, okay, sedative to the patients, okay. And then over here, the T high is fairly long, okay. So a while ago we have made mention that the T high is how many from 4 to 6 okay of a second. So once you already stretch out your T high, let us say it's already at 8 to 10, then yes, you can think that okay, your patient is fairly can be is a subject for winning. And then if your FiO2 is now 50% and lower, if you were able to keep the pillow at zero, and then patient's ABG is not showing hypercapnia, and then patient is not in a severely shock, and then patient is now assuming the work of breathing, yes, why not? Okay, so the reasons why you put your patient on APRV is almost resolved. So you can even now think of what I can win now my patient from it. So how are you going to do this? Okay, so here is now what we call the drop and stretch method. So what is a drop and stretch method? So here you have to decrease your P high at an increment of 2 centimeter. Okay, so drop it down 2 centimeter, but again consider your parameters, your ABG, okay, hemodynamic, your patient. Take a look at your patient. Then if your patient is passing the criteria like what I have mentioned a while ago, then you can start dropping your P low with an P high with an increments of 2 centimeter, while prolonging the T high with an increments of 0.5 to 2 of a second. So you can keep on doing this, maybe done with a 4 to 8 hours as patient tolerates. But then again, the weaning is depending on the protocol of per hospital. Okay. Then while you are doing this, again, so you have to monitor any episodes of desaturation. Is there any increased work of breathing? Is the patient developing tachypnea? So if this happens, then you have to stop and then again move a little back. Okay, go back a little. Okay, but okay, so go back to the point where your patient is now calm down. Okay, and then try again sometime. Okay, until you see that again you can give another trial for the patient. Okay, but if let us say for example, you are able to win. Okay, the patient is able to win, able to tolerate what you are doing. So once you reach a P high of 20 centimeter of water, 20 centimeter of water, and then you were able to stretch the T high to around 20 to 30, okay, with a 30 as maximum of a second. Because if you will look at here now, if you end up with 30 seconds, so you only have a release of only two times. So this is almost the same as your CPAP now. Okay, so if you were able to reach this point of P high of 20 with a T high of 20 to 30 of a second, so you are nearly, okay, very close to CPAP. And at this point, you can wind down now your setting to CPAP of 15, and then keep it over and 6 hour, and then make sure that then your ATC is turned on, and then you might even, okay, you might even consider extubating your patient if you have a CPAP of 10 to 15 centimeter of water. Okay, so 10 to 15 you can. So there's no need on shifting your patient to pressure support. Okay, so from APRB, just try to drop and just try to stretch. Okay, put it at CPAP. Then once you reach this portion, then you can just extubate the patient, and that's it. Okay, you can even try now what? Considering high flow nasal cannula to maintain, okay, as a support. Okay, so once patient is okay, and then maybe that's it. You try to what? Look at the patient, how the patient is doing on this. Then I think that's it. Okay, do not ever try to what? From CPAP and then go immediately, okay, to nasal cannula, because still you have to understand that we are giving high pressure, low stretch. I mean high stretching. Okay, so give a little support. Okay, until you were able to wind down your high flow nasal cannula flow, and then that's it. Okay, so just try to monitor. Okay, I think think with that, I'm done. So thank you for listening. And I hope that I was able to give you a short, small insight about airway pressure release ventilation.
All right. Thank you so much. That's very extensive and very what do you call this? We've
Uh-huh.
learned a lot from it, and I've been writing notes here left and right. But yeah, thank you so much for sorry for that. Very in depth and presentation regarding APRV. Now, if any of our audience has questions, please feel free to comment down below, and we will, Miss Riza will try to answer your questions here in a moment. So please feel free to comment. If you have any questions, please let us know. Now, Miss Riza, I do have a question. Okay, here we go. My question for you would be, so the Habashi, because it has mentioned COVID-19 on your presentation. So the Habashi, was the research done pretty recently during COVID?
Okay. So actually, they have this still ongoing. If
Mm-hmm.
you will see the APRB network.
Mm-hmm.
So it is still ongoing until now. So as you can see, research is what research is continues. Okay.
Mm-hmm.
So yes, it is.
Okay.
So
Thank.
they have done a study, and it's still ongoing until this
Okay.
time.
Thank you
I
so
can share
much.
you the link, by the way, my friend.
Oh, thank you so much. So, Ms. Riza will share us the link, but it's on the aprvnetwork.com. So, if you guys would want to look into that, the research is still ongoing. All right, let's read our comments from our audience. Ma'am, inom ka daw muna ng tubig. Baka.
Can I?
Diba? Yeah, go ahead, ma'am, please.
Well, do I have a lot of questions from there?
Yeah, yeah. So, that's
A
from
lot?
Christopher Lim. Inom ka daw muna ng tubig, ma'am, from
From
Mr. Christopher Lim.
okay, okay.
Yeah. Yeah.
Can I just pause for a while?
Yeah, yeah. Go ahead, ma'am. I will unpin you. I'll just keep talking here. Thank you so much. Please go ahead.
Okay, thank you so much.
You're
Thank you.
welcome. Okay, so to all our audience here, um, if you have any questions, please feel free to ask them. We will try to answer a question, or Ma'am Riza will try to answer a question. Um, she's just gonna take a short break. That is a very wonderful presentation from Ma'am Riza in here. Um, I'm just gonna block her camera first. She takes a break. Comment from Miss Jennifer Matibag Artilio. Thank you, Ma'am Riza. It is very clear discussion about APRV. Indeed. Again, to all our audience or viewers right now, thank you for tuning in, listening to the presentation of Ma'am Riza here, and very good um, educational opportunity for all of us here. To be honest, the APRV, we have I haven't used it for about 3 years until at my current institution until COVID-19, as there are some studies from different doctors, and there's some editorial from some pulmonary critical care doctors that they're trying to use the APRV settings to promote, spontaneous breathing, which is very, what do you call this? Could be beneficial for our patients. Um, yeah. Any questions? Please let us know. All right. Ma'am Risa, by chance, do you have any like prepared question for our audience? We will get back to her. She's currently taking a break. Anyway, update for our fundraising, which had concluded a few days ago. We were able to procure 200 units of fingertip pulse oximeter that was donated to the office of the Vice President Lenny Robredo in Quezon City Reception House. It was hand delivered, and they have received and they have confirmed. For more information regarding the ongoing efforts of our group, please follow our RTMO channel, and as well as with the Filipino Association of Respiratory Therapists International Facebook group. So that is still ongoing. We have spent about $904 for that ongoing effort, and we still have about 500 something dollars that we will be spending for our ongoing efforts to support the COVID 19 relief in the Philippines. We are waiting for our two ventilators that is about to be donated, and our contacts are still determining which hospital should receive it, and we will be buying equipment or parts for that ventilators so we can send it back to the Philippines, including some power supplies and circuits for that. So please stay tuned. I will give you an update and accounting on that. With that ongoing effort of our group. So thank you for all our generous donors, kind donors, for that ongoing effort that we have, and I truly appreciate my coworkers, my friends, and my colleagues who are supporting the ongoing effort. So, yeah. So thank you so much, and continue to support our future and current efforts to help our kababayans that are in need. Okay, you okay now, Ma'am Riza?
Yes.
Thank you, and thank you again. I know it's very what do you call this, in depth, but every minute, every second of it, I was writing down notes, and going back to my former university hospital that I work for. We've used this a lot for
Mhm.
ARDS, and it's very helpful. And now, you gave me
Yes.
a quick idea how to properly and suggestively use this APRV mode setting. Okay, reading from our comments here. All I can say on the presentation is wow, wow, ang galing ng RT mo today, Michael Di Parata. Thanks,
Wow.
Ma'am Risa Lopez. Yeah, we do
Thank
truly
you.
appreciate you, ma'am. From Novita Abelong, thank you, ma'am. From Ma'am Joy Tiglao Villorente, thank you, ma'am, for sharing. Ma'am, have you experienced using this mode from initiation to extubation? How was the experience?
Okay. So I was away from the, as you can see, like what I have told you. Okay, I'm already in an education. Okay,
Mm-hmm.
so I was away of using this APRB for quite some time. But then, yes, there are success rate. Okay, on APRV. The key here, the key point here is how are you going to set it properly. And in our hospital, as you can see, some of the doctor. By the way, we RT, we want okay to try this one, but then we want to initiate this because we know the advantage of using the APRV. But at the long run, it's always at the doctor's
Mm-hmm.
approval whether they want to do it or not. Because let us say for a doctor, if your doctor is not so keen enough on working on APRV, they will be so afraid, isn't it? I don't know, Michael, if you also
Mm-hmm.
experience having this. And sometimes they won't even want, like, for example, okay, so you were able to win down, okay, all
Mm-hmm.
the settings. And you just wanted to, okay, keep on your CPAP and then extubate the patient. Some doctor wouldn't want that.
Mm-hmm.
So better as well keep shift your patient on PSB. So yes, there are cases wherein there are what success on setting your on putting your patient on APRV. But again, uh, going back before and then looking at the new researchers now, try to review your setting, okay?
Mm-hmm.
Because even before, my dear, I'm telling you, before we were keep on increasing the T low because we wanted the measured PEEP to be, let us say, 4 to 5, 6 to 7, where actually this is not the case. Okay,
Mm-hmm.
so the success on the APRV depends on how first are you when dealing with this, how you know the setting, and then I think that's it. Yes, there are, but then it's always been a collaboration between the artist knowledge as well as the doctor.
Yeah, thank you so much for that. I truly agree. When we first had what do you call this, the surge, big surge of COVID-19, though we use ARDS and we use lung protective strategy, that the main decision will still be at the hands of our doctors. But yeah, when they hear about APRV, they would think that it's a very complicated ventilation mode, as if like it's like a last resort. But as you mentioned on your
Yes,
presentation, it can be an initial mode of ventilation, the
yes,
which
yes,
I personally think that when we don't use any mode of ventilation too often, they think that it's like a special, super special mode that they're afraid to use. But then again, I think the key to that is to continue to educate not only our fellow respiratory therapists, but also as well as our doctors, pulmonary care doctors or intensive care doctors, about this modes, because it's very some patients truly will need this mode of ventilation. And again, with proper education, proper training, and use of this, we a lot of patients would benefit from this. Instance for us with the COVID-19. Again, I'm just gonna read this comment here from Mr. Andy Palado. He shared the link from emcrit.org. Also give good guidelines on using
uh-huh.
APRV modes. So that actually, that when I was looking at COVID-19 APRV mode, and there's a lot of doctors saying, hey, yeah, we need to use this. I actually used this link, emcrit.org, and followed their suggested use of APRV for patients. And we've used them in our hospital. And I was able to, educate some of the doctors on shift, and they said, hey, we'll try this, doc, I think it's going to be beneficial. But then again, as shift changes, some doctors will like, no, I don't like APRV, why did we use that? But I'm
True,
like, it's a spontaneous mode. You want to sedate,
true,
go ahead. You want to paralyze, go ahead. But we try to keep them awake and try to use their respiratory muscles. They're afraid to use it.
true.
Again, on our part, we didn't do education with them before we use this. But then again, it could really be a good mode for some of our COVID-19 patients.
You know what, Michael?
Mm-hmm.
I think the dilemma of the doctors here is that, okay, first, the lack of knowledge on how to use the
Mm-hmm.
APRV, and then look at the graph itself. When they look at the graphic,
Uh-huh.
okay, the ventilator have the monitor, isn't
Uh-huh.
it? So by the time they looked at the graphics, and then the T high is very long with a very short release,
Mm-hmm.
so that's when they will say, okay, no, 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 no
Mm-hmm.
for this one, and someone in very high pressure.
Mm-hmm.
So they are so afraid to try it,
Right.
but then they don't understand the concept. So
Mm.
some will think that, okay, APRV is an inverse
Right.
IE, because I'm
Mm-hmm.
setting my T high so long and then my T low so short. So they were thinking of that. But if you will look at it in a very deeper, so actually it's not because you are allowing your patient to breathe spontaneously on the CPAP level.
Mm-hmm.
So APRV is just the same as the CPAP,
Mm-hmm.
okay, with some pressure released.
Mm-hmm.
So I think we just have to what, educate,
Mm-hmm.
okay, educate artists, educate the doctor.
Mm-hmm.
And by the way, there was even one study which they almost tried to put the patient on ECMO because the patient is not
Mm-hmm.
improving.
Mm-hmm.
But then they suggested, okay, put the patient on APRV. Then it was a very good setting. They understand how to set it, and then don't you know that the patient the patient did well on
Mm-hmm.
APRV,
Mm-hmm.
so they saved the patient from ECMO.
Mm-hmm.
And you know ECMO,
Yeah.
ECMO is very invasive.
Yeah. Yeah, truly agree. We need to keep ourselves and our colleagues informed and educated so we could properly and safely perform this mode of ventilations or any intervention that we do. And I do remember I've used APRV on a patient on ECMO as well. and some of them are prone on APRV. This is way before COVID, and it's very exciting. I've learned a lot. And speaking of this, you know, I think there's a perception still going on, even here in the United States, and I believe on some other countries too, that what as a respiratory therapist, you just give nebulizer treatments. You guys do massage. You guys are massage therapists. They're talking about CPT. With this presentation, you would look, and I really love your presentation because you will explain some things very detailed, and you show us a picture. So you covered most, learners here that they want somebody talking, somebody looking into a slide, and actually seeing it on action, which I do truly love. And like looking at those graphics, let me tell you, if you're not a respiratory therapist or you're not a pulmonary critical care doctor, tell me what's on that, waveforms. Tell me what those numbers means or what those graphic means.
Sure.
These are the things that we have learned in respiratory care school, and we should be, you know, continuously learning as we have our patients every single shift that we come in. Is you look at that vent, you just don't jot, jot the numbers down, but you look at those waveforms because it gives you a lot of information how you could recommend intervention and changes on your ventilator settings, right? Because if you just continue to see that and see a lot of squiggly lines in there and the numbers are high or low and you're just charting down, then again maybe we are truly button pushers, as my other might say, but then we should be like that. That's why some countries like us here, California, state of California too, in the US, we call ourselves respiratory care practitioners because we are not just therapists. We just don't provide therapy. We practice the profession and the medicine of respiratory care. That's why we are practitioners, because we could assess, we could recommend, and we also do the intervention ourselves. So I think for some people, why RCP versus RT? You guys may have personal belief on that, but for me, respiratory care practitioner sounds, you know, I don't know. It sounds bigger for me than being called an RT. But anyhow, it's a preference. I don't mind being called both. Just don't call me or my colleagues respiratory technicians because that's not the case anymore. Yeah. So, any more
You know what?
questions? Go ahead, ma'am.
You know what, Michael? You know what, Michael? I'm always emphasizing this to my orientee. Okay, so every time we have the rounds, so the rounds artists should be there. Okay, now what you usually hear from the RT. Okay, so what is the ventilator setting? So they will just end up with, okay, this is the FiO2, this is a tidal volume, this is the rate, and so this is the PIP, and this is the APG. I was telling always them, okay, you can tell more rather than just telling me the setting. Because for the setting, I can just go there and take a look at the setting. But then what about telling me about the pulmonary mechanics of your patient? How is your patient responding to your setting? What about the plateau? Plateau can give me a lot of things. What about with the axial tidal volume? What happens with the compliance? What happens with a lot of things? You can even you can give a lot of details that will help even the doctor to come up with a good management. And definitely, I agree with you. The ventilator is not just there to give you the numbers. The ventilator comes with the graphics. So you should know how to understand. You should know how to interpret what is the volume waveform means, tells you, what does the flow tells you, what is the pressure telling you, what is the loop telling you. So try to maximize all of this. And I always emphasize this as well. Okay, for us, we should also understand how to read chest X-ray. So it's not just looking at the what? It's not just looking at the tube. Where is the tube? Is it 3.5 above the carina and so blah? No, it's not. So try to go deeper. Understand. Okay, is there hyperinflation? Is there any? We RT. I definitely agree with you. So that's why here in Saudi, okay, there's a high respect when it comes to RT because even CT, we are not so good, but then we can detect where's the problem. Is there hemorrhage or whatsoever? So you have to come up, and even in the Philippines, I want it. Really, I'm eager. Okay, so we have to try. Okay, go get out of the box. Okay, tell the world. Okay, that we understand, we have the degree, so we can help, we
Mm-hmm.
can help. So I think this is one of the things that, okay, I really want to emphasize to all artists.
Yeah, thank you. I agree. I truly agree with everything that you say, that you should just not go there and jot down numbers and do this and do that as that hospital normally do. You have to continue to be curious about your patient, looking at your imaging, looking at your labs, chemistry, CBC, gram stain, whatever
True,
it may be, right? If looking at your x-ray, if
true,
they have broken bones and you're having problems ventilating them, maybe because that broken rib is causing that high pressure on your vent, right? So you could change your motor setting. You could tell the doctor this is what happened, and then looking at your imaging too, you could see maybe there's hypo or hyperinflation, whatever it may be, or consolidation. And what is that consolidation? Maybe you can fix that with your vent. Maybe you could recommend, hey doctor, I think we're having some pleural effusion. How do you treat that? There's a lot of things. We are
true,
practitioners. We are very well rounded, like Miss Risa said. We could do so much more.
true.
Yep. And also, any more questions, concerns, please feel free to leave a comment here. Now, Miss Riza, I forgot to mention to you earlier when we did the pre-brief before we went live. Do you have some uh, questions ready, or you have some questions at top of your head that you can share with us? Because, we normally do like a Q&A um, respiratory therapy game after. If not, I jot down some.
I can give, I think, two questions.
Okay, go ahead. So,
Okay.
give me one
So,
second here, ma'am. So, again, here as we normally do in every episode, we do have question and answers from our guest, and whoever gets the most point will win our prize. And for today's episode's prize again, which is sorry easier for me and easier for the recipient too, is I'm giving gift card instead of actual cash because it goes through a lot of channels with cash and asks for a lot of information. So price for today's episode will be a Shopee gift card, which is like your Amazon, eBay in the Philippines. So again, mechanics would be answer the question, type in on the comment section. Whoever gets the first and correct answer will get the point. The most points that you know, the person who gets the most points will be the winner for this game. And we will start. If you guys are ready, ready your fingers and have your listening ears on. And here are the questions that we have. Go ahead, Miss Riza.
okay. One of my question is, to which condition can we allow p height to be set more than 35 centimeter of water? Or to what condition can we allow p height to be set more than 35 centimeter of water?
Okay. Which condition or which patient that you can set your initial P high greater than
Yes,
35 centimeter water pressure?
centimeter.
Okay. So I can give some options here. Letter A would be a COPD exacerbation patient. A, COPD exacerbation patient. Letter B, obesity or patient with increased compliance, increased thoracic or abdominal compliance, like a morbidly obese patient. Letter C is patient dealing with a smoke inhalation injury. A, COPD exacerbation. B, increased compliance or morbidly obese patient. And C is a smoke inhalation patient. Okay, leave your comments or your answers below. A, B, C, or D. Which uh, patients or condition would you suggest or initiate with a P high greater than 35 centimeter water pressure? A, COPD exacerbation. B, morbidly obese patient or patients with increased compliance. And letter C, smoke inhalation patients. Come on. Answers. Okay, feel free to answer. And if you're based overseas, then we can have a proxy be sent to anybody from the Philippines. Okay, so A, B, C, or D. Okay, while we're waiting for answers from our audience, stay tuned for our episode for next week. I will be posting whoever would be the guest for episode 10 of our Timo. We are now at our ninth week. We have our weekly episode, and hopefully we can continue with more episodes in the future. As everybody know, I'm back to work. I'm working again. I've been off for 3 months, but I'm working back again, so my schedule's kind of different too. So we might consider doing bi-weekly episodes instead of weekly episode. Okay, so I think I have a poll here. We don't get an answer. What's the answer, ma'am? Ma'am Risa, what's the answer for your question?
Okay. So the answer for the question is those patients who are morbidly obese.
Okay,
Okay,
awesome.
we are having a decrease in compliance, thoracic as well as abdominal.
Mhm. Okay, all right. We don't have anybody answered that, but next question, ma'am.
You can ask. You can ask.
Okay, no worries. So this is what I'm gonna do. I don't think we got enough people here to answer question. I have a poll here. So I'm gonna. I have like about 15 question here. It's just a review or recap of what we did here today. Um, okay, and then people can answer. Okay, activate poll. Here we go. If you are on Facebook Live, I just activated a poll. Hopefully it's working. Let me see. Oh, here. I don't think it's activating. Oh, publish. It's not activating. Okay. Any questions, concerns? I'm trying to activate poll here. Click on it. It's not working. Maybe I just don't know how to use this. But did it work? Activate poll. Here we go. I think the question here is what is hypocapnia may be indicative of? A would be worsening ARDS. B is patient is may be ready for weaning, or letter C, hemodynamically unstable patient. Okay. Well, I have all these questions, but it's not activating. Oh, here, there you go. I have an activated poll again. Here, you guys can see this. I don't know how it works. Activated again. The question is ATC should be set at, or the automatic tube compensation should be set at A 100%, B 50%, or C 25%. Okay, that's fine. It's not working properly on my end. But anyway, Miss Riza, we thank you so much for this great presentation. We have learned a lot, and now we can definitely use it in our practice, and we could better talk to our physicians about convincing them to use APRV on our ARDS patient. And as we know, some a lot of critical COVID patients, leads to ARDS. So we thank you for your time and for your effort and for your very in-depth and very wonderful presentation. Um, any closing remarks for us, Riza?
Uh, I really appreciate those who watch. And then since I think this will be uploaded, so it will be a great help for everyone. Okay.
Yes, ma'am.
So again, with the COVID that we're facing right now, so keep the faith, and then for sure this one will end soon. So hang on. And then again, I will always emphasize that RT, we can still, okay, move forward, don't stop, okay? So go and research if you want research, continue, get out of the box, show the world that yes, we can. RTs, especially Filipino. So Filipino, we can do more, okay? Knowing we are hardworking, we are resilient. So that's it. Good luck to everyone, and I hope that I was able to help you in in all good ways. So that's it. God bless everyone.
Thank you so much. Oh, here, sorry, we got some. It's so weird, but we thank you, ma'am. I'm not getting this. I think somebody are answering our questions, but all right, we're gonna. I'm having technical difficulty on my end here, but we do thank you, ma'am. Appreciate it. We will upload this. This will be available for stream on Facebook for the next few hours. If you don't see it anymore on our RTMO Facebook page, it will be uploaded on YouTube. So please stay tuned. Please stay educated. Please stay informed. If you have any questions, suggestions, or concerns, sorry, excuse me, please shoot us a message. Shoot the Ang Artimo Facebook page a message, or if you are friends with me on Facebook, please send me a message, and we will gladly entertain those comments, suggestions that you guys have. And if you are a fellow respiratory therapist, please, if you are interested to share knowledge, experience, and expertise on any respiratory care related topic, please do reach out to me. We would love to have you on the show as we keep our fellow respiratory therapists informed, most especially in this difficult time. And then again, we thank you all to all our viewers, our supporters, our followers, our group members on Party. Please, if you have not liked the page yet, please do like our Facebook page. If you're a fellow respiratory therapist, please join the Filipino Association Respiratory Therapists International. Please like and subscribe to our YouTube channel, Ang Artimo. And we will see you on our next episode of Ang Artimo. This is your host again, Michael Di Peralta, and with Miss Riza Lopez for episode 9. We thank you. Have a good morning, afternoon, and evening. Thank you so much.
Okay, thank you.